welcome to this session on how the use of routine medical scans could soon replace the need for invasive biopsies, currently a mainstay of cancer diagnosis and monitoring. Joining me is Tristan Lawton, Chief Clinical Officer from Canon Medical Research Europe, and Dr. Evis Sala, Professor of Oncological Imaging at the University of Cambridge. Professor Sala has been leading a research team that has layered MRI and CT scans with ultrasound imaging to greatly improve the precision of biopsies in ovarian cancer patients. This research could pave the way for non-invasive virtual biopsies in the near future. I'll hand over to Tristan now to discuss this exciting research in more detail.
Thank you, and welcome everybody, and welcome Evis. I'll just jump straight into the questions. Can you summarise the research you've been conducting in ovarian cancer in particular?
So what we've been doing in the past sort of almost 2 years actually started before the COVID pandemic, and we managed to keep it going through the pandemic, is trying to build up a program where we can eventually replace or at least limit the number of invasive biopsies. And in order to do that, we have, in collaboration obviously with Canon, we are overlaying together CT and MRI images in ovarian cancer, CT images, which have heat maps of radiomic features. And I'll explain in a lay's language what radiomic maps or habitats mean. But those overlays are then the radiomics and the CTs. They're overlaid with the ultrasound or fused with the ultrasound, real-time ultrasound. In a simpler term, a patient has a CT for staging of ovarian cancer in this project. Then the computational team does the magic with the numbers and extracts tumor heterogeneity. These are overlaid as color maps on top of the CT. Then when the patient comes for the biopsy, this is then fused in real time with the ultrasound. So the operator, the consultant radiologist, sees on what they see on their screen is actually the fused CT and ultrasound, and then the ultrasound itself. So when they guide their biopsy, rather than just guiding it to the tumor anywhere, which is obviously safe, they'll guide it to the areas which look different on CT because they have this different phenotype, different imaging appearances. The idea is, can we actually make biopsies first more meaningful? So we not only direct the needle to be safe, obviously to the tumor, but also to various areas of tumor which may contain different biological information, genomic information that ultimately might change the way we treat these tumors. Parts of the tumors might be more aggressive. By just sampling one piece of the tumor without this sort of information, maybe we're missing some information which is relevant then to treatment. So this is sort of in a nutshell what we're doing. Let me just explain what the habitats mean, because it might not be that as clear, but try to picture yourself like a painting of Mark Rothko, right? Which is a relatively sort of blunt in terms, it's wonderful, but it's blunt in terms of how much sort of heterogeneity it has. And then a Jackson Pollock painting, which is all, movement and a lot of colors and a lot of, the Rothko painting will be fairly homogeneous and the Pollock painting will be very heterogeneous. So that you can say with your bare eye, but you can also quantify it. When it comes to CTs, the CT tends to be blunt itself, so you can't really see what I've described. So you are using this quantification in a method to actually then be able to visualize this heterogeneity, and you can then produce a Rothko or a Jackson Pollock depending on how heterogeneous the images are, and then overlay this map with the ultrasound in real time. The immediate sort of goal is, are we sampling correctly? Yes or no? Is there any biological meaning behind what we're sampling? Are those areas different? But ultimately, can we actually start doing less biopsies on patients on trials, not coming all the time for repeated biopsies, or even choose the more relevant lesion, which is going to drive the resistance, and then down the line, in a bit more future, maybe replacing the biopsies altogether?
What you're describing is essentially, today, we are taking the images of the cancer, and with your analysis and research, we're diving deeper into more detail that may not be visible to the human eye, but actually from your excellent and very sort of clever AI people and computer science are helping sort of develop that in that research. So how different would this be from the current method for the diagnosis? How are patients diagnosed today for ovarian cancer?
So in ovarian cancer, I mean, ultimately every tumor needs a biopsy, but the pathway is slightly sort of different for ovarian cancer. I mean, it is a silent killer, so unfortunately the symptoms are very non-specific. So rumbling pain, bloating, by the time the patient seeks medical care, it's a little late, so it presents a metastatic disease. So the first thing is done is a blood test called CA-125, and when that is raised, it's an indicative, it's not specific, but indicative of ovarian cancer. And then a CT is performed to look at the extent of disease and also assess what is the best spot to actually then biopsy. And then ultimately, obviously, they could be mimics, it could be a colon cancer that has spread into peritoneal cavity. So you really need a tissue diagnosis because the treatment will obviously depend, the cocktail of chemotherapy will depend on the type of the histological subtype. So now we've so many treatments available, so you really have to match it. Currently, then the patient comes to ultrasound, and then the biopsy is guided by the ultrasound, which is actually quite tricky because sometimes an ultrasound, that's sort of what we call a mental cake, which is the area we mostly biopsy because it's safer. It's sort of relatively superficial anterior to the bowel. Sometimes you can't see it on ultrasound. It's really interesting how you start to research actually with something on mind, but what we found in a couple of the cases, without having those overlaid maps, we couldn't have safely biopsied it. And it wasn't what we set out to do, but that's the beauty of research, isn't it? You set out to do something and then of course you'll complete that, but there are other things you find out, which makes it very exciting. So it would be very exciting to see actually a couple of times in 2 or 3 patients, it was just day and light. We switched on the fusion and there it is. And we could really, guide the biopsy to the tumor. And if that wasn't available, we would have then used the CT to biopsy, which is not that easy, because the omentum moves with the bowels. The CT is not an easy way to biopsy. And most likely those patients have gone to a laparoscopic biopsy, which obviously has the anesthetic and the other. So I could see this actually helping us guide the biopsy much better, to visualize it anyway, but also then to get more meaningful information. So kind of shift the paradigm. So currently this is the what they do, the CA-125, the CT, and then the biopsy on ultrasound. And then obviously we'll get the biopsy result and then the treatment will start. Just one thing I want to say, our newest way, what we've tried to do is actually we've tried to fit in patient journey. The fusion is absolutely fitting in patient journeys. What the computational group does, it's in the background, right? So that doesn't actually delay anything for the patient. It will be a normal delay between the CT and the biopsy, right? And the ultrasound. So we're using that window to actually do all the computational work. And when the patient comes to biopsy, all is preloaded and ready to go. So at most, because of the fusion, at most will be another 10 minutes extra time for the patient. So that's why we actually didn't stop our research program. It got slightly delayed because some patients were a bit more obviously worried to have 10 more minutes due to COVID. But actually we didn't stop all the way through COVID, those biopsies, because they were part of our clinical pathway.
You referred to a few times fusion and the fusion of the CT, the maps, the habitats, as you refer to, and the ultrasound. How has the fusion technology helped, and how can it help in any future targets?
If we didn't have the fusion, you'd be sort of looking at the CTs and the habitats on one monitor on PACS, and then you're just trying to match it, on your ultrasound, which is really tricky. It is safe because we still use ultrasound to biopsy, but in terms of, it has in 2 modalities separately downtime without actually any opportunity to really accurately know where you're going. And you would have absolutely killed the biological sort of understanding question, because obviously you can't be sure that you're sampling that habitat. You're sampling the tumor, of course, but you're not really sampling the heterogeneity of the tumor, which is key. And one of the key points to make is that it's currently not in routine clinical practice, but if you can think of multiple drugs that are being tested in clinical trials, you want a quick readout. You want to make sure that the drug is working after 1 week, after one cycle of treatment. So you want to have a way to at least inform if that's work or not. And you can't really biopsy every week. It just every after cycle, you can't just biopsy in the abdomen. But if you have an indication, if that heterogeneity is changing, you can track it even without biopsy with the fusion, and heterogeneity, that will be a step. Of course, at some point you need to biopsy, and that's why the fusion is the way to go forward. But ultimately, down the line, maybe just not using the biopsy at all.
So this is where in the introduction, we talked about the potential for virtual biopsy.
Yes.
So you're talking that it may not totally replace biopsy completely, but it may replace multiple biopsies in some respects.
Correct.
And is that just in the diagnosis side, or do you think it's more in the response to treatment?
I think when it comes to diagnosis side, I think our biopsies will be more precise. I'm not saying it's more precise in terms of safety, because obviously all our biopsies are safe. You biopsy the tumor and, but more precise in terms of we were learning continuously on how those heat maps correlate with the genomics and histopathology. So then we will aim to biopsy the area of the tumor, which we think from imaging, or we believe we have the data, it's more aggressive, or two different areas which are distinct. Then we can see how this tumor evolution will be during treatment. Ultimately, there'll probably be another biopsy to really look at or the biopsy could be timed. If you actually see any meaningful changes on those heat maps, then the decision will be, right, this is the area to biopsy because this has changed in a way that we don't like. For example, the blood flow is different, depending on what we're using, depending on the drug we're using, because obviously there are changes in the tissue which are specific to the drug we're using.
That's really helpful. And I'm just wondering as well, you've chosen ovarian cancer as the first target. Are there plans to move into other targets or other cancers using similar sort of?
So yes, actually we have already moved to kidney cancer, and the reason is twofold. I mean, kidney cancer is very heterogeneous. We do use biopsy to make some of the, diagnosing in certain occasions, but also we've started a trial which is called the Window of Opportunity trial. It's quite novel design, actually. And what it means is the patient will have, there is a window before they have the surgery to take out their tumor, the kidney cancer. And in that window, chemotherapy or a combination actually of, there are various arms of chemotherapy and immunotherapy is given. So treatment is given, and then so we image, we take the biopsy. Then the patient will come back. We will again image and take the biopsy, and then it'll be more treatment, and then we'll come to surgery and the tumor will come out. So we have the opportunity to actually test in the patient what drug combination worked for that patient, and then use that combination to treat them after the surgery, because it has to be completion chemotherapy. So it'll be chemotherapy, surgery, chemotherapy, and that window between the first chemo or the diagnosis and the surgery, it's used to test those combination of drugs, hopefully choosing the right ones. It's quite an advanced idea, actually. It's quite personalized, not just to a tumor, but to that patient. And we're now then using the imaging and the fusion to actually absolutely accurately biopsy those areas. And because we're using MRI with multiparametric, we also are probing the physiology, right? With the CT, you really measure, it's a gross perfusion, right? How much the tissue announced. With MRI, you can actually probe exactly the physiological parts you want to probe. With diffusion, you probe cell density. With perfusion, permeability. And then if you were to have an MR PET, which is not in our case, you would probe metabolism. So there are various areas you could look at with MRI that you can actually understand the underlying physiology. And then the maps are generated similarly with a unique combination of those. So you still generate the habitats. So that's sort of in kidney cancer. And again, out of the research question, that what we said was this in mind, but then the team found it very useful actually to start biopsying every single biopsy they do clinically now using fusion, because they're small lesions that can be difficult on ultrasound. They have the CT, they fuse it. So now almost routinely we're using fusion to biopsy small renal lesions because feel more comfortable, feel safer to do so. So it's that sort of a benefit which actually is more tangible right now to our patients. That has been a very good extra, a lovely surprise actually.
You mentioned about the benefits to patients in this research, particularly with this window of opportunity trial, about it being more personalized. And so I'm assuming that means we're assuming better outcomes for the patient. And is this a model that would move on to other cancers as well?
So yes, so we actually are. So in ovarian cancer, we're doing it as a proof of principle in the standard of care, sort of platinum-based treatment. But we are very close to going through approval of a trial which would be similar. It's a neoadjuvant rather than window opportunity. In ovarian cancer, we're going to use MRI, and it's going to be multi-site. So in ovarian cancer, because it's metacyclic presentation, we will have the ability to look at the whole tumor burden, and then really not just choose the area, but choose actually the lesion you want to follow in biopsy, which, funny enough, we always think that you should really, because it's sort of what we know from recent measurements, you always choose the bigger lesion, this is the index lesion. Not necessarily. We've now seen that the bigger lesion, I mean, size matters, but not always. Sometimes tumor can be small and extremely heterogeneous, and is that small tumor and very heterogeneous, it will actually drive the resistance. So I think what we were going to target our biopsies in a much more meaningful way to actually look at the tumor evolution in both space and time. This is to come, hopefully in the new year, just pending some of the funding and the approvals. And then this is a prototype, so we can use it in many other tumors. One thing that we are very keen to do, we've been granted funding for a new immuno-PET tracer. And in Cambridge, this is a multi-center European study in its metastatic tumors on immunotherapy. And in Cambridge, we will use our PET-MR to image patients. This will be even more sophisticated because there'll be a new antibody, CD8 antibody, and that will be taken into account when we drive our habitats, and we'll use the fusion MR and ultrasound to biopsy the lesions that can be biopsied, obviously, because there'll be some bone lesions, which might be difficult. But it will be a small cohort of patients, which I think will be very valuable because they'll be on a novel imaging, novel drug, and they'll have the repeated biopsy. So we'll learn very much about the biology of the tumor. So it's a bit more of a, more immediate effect. We can see the tumor better with the fusion, so we can help patients now. But there's also more sort of strategic goal of really we're using expensive drugs. We just have to make sure, they work, and we have to make sure they work or not faster. We can't just wait for years for a trial to complete. We want to really use imaging to make those decisions faster.
It's interesting you say using imaging to make things faster. And I think one question I was thinking, particularly around the research for the ovarian cancer, is what are your thoughts on how it would be translate into clinical practice, that it would be used every day as part of the clinical pathway? What route would you imagine that would be, or how far away are we from that?
The technique per se, we already have work to insert in clinical practice. And this is something I always like to do, because if you really don't do it at the beginning in terms of just the process of it, right? The framework, then you struggle, and I think if the research remains blue skies and doesn't really get into being used in clinical practice. And key to that is patient recruitment. So patients feel much more comfortable to actually say yes. I mean, patients are wonderful. They'll say yes to advanced research, even they know it might not help their actual case, but it will help the next patient coming along. When there's poor recruitment, it's usually us who recruit not doing the great job, but actually patient always wants to participate in the recruitment. So, but they're more likely to be receptive if it's not going to change too much of their flow, because you get the diagnosis of ovarian cancer. It's a devastating diagnosis. You've got to sort out the support. You've got to start chemo, surgery, long surgery. It's a lot going on in your mind. Tests, everybody's throwing tests near, and you're healthy 2 days ago, and now it's another test, another ultrasound with the fusion. So all this adds to complexity. So if you actually then insert this in the normal pathway, because they're coming for the biopsy anyway, and you really explain that, look, this is going to look at your tumor in a much more detailed way, they're really, really very keen to actually help. So that part we've done, but what we want to do is to actually then shorten the process, because right now the whole radiomics and their habitats of extraction happens in the background, and it does take the time. And I think, we need to make them more seamless. Basically, the CT is done and actually on the fly. As you report in the CT, that's all generated, gone to PACS. So when the patient comes, everything is there available. So that will need a little bit more time, because as you can imagine, our work works perfectly fine on a research university environment, the part of the computational, but then you've got to then work with IT to integrate it. And I don't have to mention, what the IT of the hospitals is nowadays in terms of and there's pressure, I understand that, we all understand there's pressure, the COVID has brought them. But I think that will be the goal. Why can we, in the next, 2 to 3 years, move this from a trial and research only to these biopsies are going to be done routinely. We know that can be done with only 10 minutes extra time, but then all the computational part is done on the fly as well. So as I report a CT for staging and qualitative describe it, the whole in the background, the radiomics and habitats and everything is done. So when the patient comes for ultrasound, it's all done, rather than having 3 people getting all the extraction done, uploading. I mean, they all love it and it's part of research, but I think we want to shorten those times. And I think this is This is a generic problem, though, in a way. Is sort of translating the academic part to actually the clinical routine. It just takes a bit of time sometimes.
And I think actually it's been mentioned a couple of times. You've mentioned radiomics, and a lot of our viewers may not know what radiomics is or what it means. Give us a brief overview or for some of our viewers so they can understand what we mean by radiomics.
Of course. So I made sort of the paintings reference. And when I said the texture is one of the metrics you use for radiomics. So radiomics is really large scale quantitative image analysis that you extract features from any photograph, being that pathology, being that imaging, that is not possible to perceive with the bare eye. In general, in clinical practice, we are very qualitative. As most as we go, quantitative is measuring a dimension. With imaging, we've kind of remained a little bit with a ruler. Definitely have gone using pucks compared to printed films, but we still use a ruler. In the old times, we used to draw a line in a piece of paper and just measure it. This is when I trained. And then we had pucks, which is great. So you've got an electronic caliper, but it remains a measurement. So what we want to do is actually to turn those images, to actually mine that data that is hidden there, like a parallel with the genomic data, and make this available. It will take time at the S to go through biomarker qualification. There are efforts being made. But literally, for a lay language, when you think of something that you can't look at the heterogeneity with a piece of paper, really, or a photograph, just a photograph, you can derive so much by quantifying what is hidden there. So it's this large-scale quantitative data analysis. And you'd say, well, why haven't you done before? But now it's the computer power is such as we can do it. So it's just all about the computational power.
As a vendor and speaking to sort of leading researchers in this area, in terms of oncology imaging, what is next for you? What are you looking forward technology-wise from imaging?
Imaging inherently is a field that it always progresses technically, so there'll be the next sequence and the next reach and the next development. And it's great, it'll be faster. But at some point, I think sometimes we lose the track that actually maybe having a sequence which is slightly higher resolution doesn't actually make a difference to the diagnosis. Okay, so we all like the new choice. You can have an iPhone 6 and perfectly do everything. You don't have to have the iPhone 13, whatever the version. It's beautiful, of course, but I think you can still make the same call. I think some of the efforts, and I think there has been a realization of that with the companies. They've now directed a lot of effort on the workflow, optimization of the workflow, the speed, the efficiency. And I think the other thing I want to see, and we're working with that with various partners, is actually, can we make a difference how we integrate the data? So right now we kind of aggregate the data. If you think of a dashboard, everything is sort of, we don't even, I've got to the stage of aggregation sort of beautifully, but, there'll be the imaging, the pathology, the clinical details, and it's a bit in silos in a way, right? And we discuss them and present that at the tumor board meeting in the US version or the multidisciplinary meeting in the UK version, decisions are made. But are we actually doing the best for the patient? Yes, the best we can currently, but I think the best will be to kind of start integrating this information. The information doesn't come as, well, the imaging said that, the genomics said that. No, that the information should be, right, the genomics taken from this part of tumor, which is informing us about how vascular the tumor is, and this drug can work because Mrs. Smith has this profile of radiogenomics profiles of imaging and genomics and clinical details, and this is what she did during her treatment. This is the last 1,000 patients with a similar condition, and these are the similar patients, and this is how maybe we can treat her next when she recurs. So I think that's this will be the power of AI, which will integrate the imaging with the clinical details, with everything. So yes, I think it's great that the companies are going to be working on the next scanner, which will be, let's say, MRI in the next 12 tests, or whatever it is, and the very fast CT, but the workflow and the patient in the center, that also is very, very important. And I think we've seen this move already, which is brilliant. Being more flashy sometimes doesn't change the diagnosis, really.
I suppose the research that you're doing with your ovarian cancer research with the habitats is part of that. Is bringing in the research that you've done in amalgamating the data from the excised tumour and doing the pathology analysis and matching the images, the sort of pathology images right up to the imaging features, as you've mentioned earlier on. I think that is how we can present that.
Exactly. And then the decisions are made properly, because, invariably you'll have cases when, maybe you see the tumor is increasing in size, but that actually, if you look at the structure of the tumor, it's becoming more cystic because there is cell death happening. So if you were to use the measurements only, you'll call that patient a progressive disease, but actually the patient is responding. And sometimes the CA125 will lag in time. So it takes a week or two more to actually see the drop. So how do you actually get all that information together and maybe incorporate the ctDNA? We've got some work with ctDNA. You can see that it's going down. So kind of build those bioflags. So when the clinician sees the patient, or when they discuss it at the MDT, or even discussion with the patient himself, that information is summarized in a way that is quick to understand, quick to describe, quick for the patient to and simple to grasp. So then the decision is made. Well, this patient is going to stay on this treatment. It's great. Next. So this is what we want to do. And I think it has to be done together, and I think as much as the stuff we think I know you're an imaging company, but you're beyond an imaging company. I think it's the other streams that come in. And I think that's how I see the future, that there'll be some merge of the imaging companies with genomics companies, with, partnerships, and bringing them on board to deliver that, because we can't really deliver things separately.
I think you're absolutely right. I agree totally. And I suppose a last question is, what's next for you in regards to research?
So what we want to do is this is stuff, I know it's been 2 years, but 2 years is not a long time, especially with COVID on the way, right? What the group wants to do is actually to see the wire child to the end, to learn to actually discover this heterogeneity behind the habitats, because obviously as we're recruiting patients, we can't analyze it yet, it's all blinded. And then see the ovarian cancer trial as well in the neoadjuvant setting, and then down the line, or parallel actually, really get to a dashboard that we can actually integrate the data, even if it's simple. And actually, no, it has to be simple, because it has to be focused, simplified, contextualized. If you start going sort of complicated, then you don't really deliver what you aim to deliver. So that will be the other part. I just want to see through, at least in the next 2 to 3 years, a prototype of an integrator of data, which has got very simple parameters, the age, the patient, the some of the clinical factors, let's say the CA125, some of the heterogeneity information, where the biopsy comes from, how the genomics tie the biopsy, and then what is the recommendation for what treatment solution. Of course, with the human input. This is only a decision support tool as an advisory rather than sort of, replacing anybody. In a way, when you think about it, the patient is integrated, right? It's the patient, right? It doesn't come with imaging. It doesn't come with, and we unpick the patient, which we do separately when we image, when we do the biopsy and everything. And then we have to find a way of integrating them together, all the information. So it comes back to the patient in the center. And I think somehow we've started doing it, but somehow it's a long way to go. If I were a patient, I would love to see visually, at least, what's happening, rather than somebody in their office scrolling through my CT scans and look, this is where disease is. Then look, but your histology shows this on a piece of paper on a screen, rather than a dashboard. So that sort of information, your mutation is coming from this exact part of the tumor, and you just feel more involved, and more sort of empowered actually to go through treatment and to succeed.
Some very promising research and a fascinating discussion on the future of cancer care and the opportunities for the integration of imaging, genomics and other patient data to build a full picture for patient care. Dr. Evis Sala, Professor of Oncological Imaging at the University of Cambridge, and Tristan Lawton, Chief Clinical Officer from Canon Medical Research Europe. Thank you both very much for your time, and thank you for your company. Goodbye.